Welcome to the ViOL Webinar. My name is Jimmy, CEO, a clinical educator at ViOL, and your host today. Today's webinar is titled The Many Indications of Fractionated Microneedle Radiofrequency for Effective Results with No Downtime. And the special guest speaker is Dr. Klaus Fritz. Dr. Fritz is the Director of Center for Dermatology, Laser, and Aesthetic Medicine in Landau, Germany. Also, he is Associate Professor at the University of Medicine and Pharmacy, Davila, and a board member at DDA, ESCAD, 5cc, EADV, and ESLD. He will soon share with us his clinical information and experience with the use of Silpam X. Before we begin, I have one housekeeping note. There will be a Q&A session after the speaker's presentation. If you have any questions, please leave a question by clicking the Q&A or chat icon at the bottom of the screen. Questions will be collected during presentation and discussed in a Q&A session. Now, without further ado, let's move on to the speaker's presentation.
Yeah, thank you very much for the introduction, and thank you for joining us here on this webinar worldwide. I'm supposed to speak about fractionated microneedle radiofrequency, and I use that kind of procedure since a decade, and I'm very happy with it because it has so many indications. That is why I also called this presentation The Many Indications of the Fractionated Microneedle Radiofrequency, and I also called it for effective results because it is very effective and with no downtime. It does not ablate, it does not vaporize the skin, it does not leave any wounds. So it is a procedure which is suitable even for darker skin types and is very soft and very shallow for the patients. And this is what I like about that kind of procedure. And that's what I want to present to you. Also, I want to present to you what are the basics and what makes the difference among the various devices and what are the variations that we have an influence on that we can use for the various indications. Now, let's go to the one basic which has some of differences already. That is radio frequency. We apply radio frequency, and looking at radio frequency, we have to know that radio frequency is not just something like we say for lasers. Laser beams are also not just one single procedure. There are many wavelengths and they are much different, and also the indications are much different accordingly. Same with radio frequency. We have mono, uni, and bipolar. Then we go to the microneedles and the other parameters. Now let's have a look on radio frequency. This is, other than the wavelengths of lasers, so-called color blind. It's a kind of a volumetric radio frequency tissue heating based on electromagnetic waves that needs some epidermal cooling, but by heating it can do, in the dermis for instance, some tightening. The whole procedure is based on Ohm's law, where energy in joules is defined and impedance is defined. The types of radio frequency is mainly these types: the unipolar, bipolar, and then the way to deliver bi and unipolar, not through the epidermis, but below the epidermis directly into the skin. What is the difference between unipolar? We could add even monopolar. Uni and monopolar have a single electrode. The energy is at the boundaries of the electrode, so it needs a lot of cooling on the surface. And where the one is unipolar, has an electrode corresponding to the applicator. Bipolar, in bipolar, we don't have the electromagnetic energy flowing through the tissue or through the whole body. It just flows between the plus and minus pole, and this means that electrical current between the two electrodes is very limited in penetration depth. The depth is just half of the distance between these electrodes. What happens if we deliver not through the skin, through the epidermis, into the dermis, or even deeper. If we do that with microneedles that are first brought into the skin, penetrated into the skin, and once they are penetrated, then like a shot, they deliver the radiofrequency in the tissue. That means there is no epidermal damage. We don't need that much of cooling because the heating does not occur on the surface of the skin. It occurs just between the electrodes, along the electrodes, but in the tissue already. We have the option of delivering much higher fluences than delivering through the epidermis, and to heat the epidermis and mainly dermis without major ablation and without major downtime. And that's the difference to lasers. How can we do that? Microneedles, they differ in various degrees and deliver in various intensities. They differ in length, in the way, if they're coated or uncoated, the way of their penetration, and the number of shots. First, let's outline the comparison and the difference between laser and microneedle RF. The laser, fractional or ablative lasers, they are vaporizing a small tunnel. Around it, we have necrosis and coagulation, and around that, we see some protein denaturation. However, in the center, we always have a wound, so we need some wound healing, we have some downtime, we have some disadvantages associated to a wound that we create. With a needle, we just penetrate the tissue, and then we deliver more or less the same. We deliver vaporization a little bit, but especially necrosis and protein denaturation, but we deliver it where it is supposed to be, where we wanted to have the collagen rejuvenation effect. You see this in this histology picture on the left side here with my cursor. I show you, this is the wound that we create with a ablative laser, and around there we have the coagulation. If you look at the radio frequency microneedle, so we go into the tissue with a microneedle and we create some coagulation around this needle in the depth of the dermis without having any wound and any damage to the superficial layers of the epidermis and dermis. And these are the two various tips. So the deep dermal heating and necrosis with perfect epidermal sparing other than ablative lasers. We see that in this stained histology for a 1.5 to 2 millimeter penetration depth, or a more superficial one, 0.5 or 0.8 millimeters. This 0.5 is a laser ablation. You see the ablation, you see the wound, and even if we go deeper with a microneedle, we don't have any wound on the surface. Usually the penetration that we can select on the device has to be selected according to the indication. So for rejuvenation, tightening, pores, and acne, superficial acne scars, we rather select a superficial penetration of 0.5 to 0.8 millimeters. If we have lighter scars, atrophic scars, then 1.5 millimeter might be a good choice. If the scars are deeper, if we need some lifting effect, we go deeper to 2 millimeters or sometimes even to 3.5 millimeters. Usually it is about 0.2 millimeter less than it is indicated on the device, because we still have to push the needle into the tissue. And the radiofrequency irradiation occurs up, down, and in both sides of around 0.3 millimeters of the needle. We have to be aware where we are treating, because the epidermis and the dermis thickness are different on our body. Like we have very thin areas on the lower lip, on the tip of the nose, on the neck, there is just 111 microns, for instance, eyelids, it's 130 microns. Other than forehead or upper lip, we have 150 to 200 microns. So there we need a thicker penetration. We need to know these differences in order to select the best penetration depth. Second difference between the needles are the question if the needles are insulated or not insulated. Insulated means we penetrate a needle deep into the dermis or in the tissue, and the heating occurs just at the tip, because due to the insulation, there is no radio frequency given to the tissue around the needle. This can be very helpful for very sensitive areas where we want to be very precise in terms of a layer. It can be also very helpful in pigmented skin because we go deep first, then we deliver the heat so it does not touch the melanocytes on the epidermal junction. However, for tightening and for more intensive effects, we need an uninsulated needle, which means we penetrate with a needle, but the radio frequency there is distributed around the whole needle, around the whole length, the entire length, which gives a little bit more pH risk, but this is also depending not on the penetration and the coating, it's also depending on the way of the fluence and the number of passes we do. And then there's another difference that we see between insulated and non-insulated. If we use insulated needles, we hit a little bit the vessels, but don't coagulate the vessels. And that's why we get these pinpoint bleedings, or we get some bruising and a little bit of a bleeding during the procedure. However, we don't get that 20 minutes after the procedure. Then we just see a little bit of redness. However, that amount of bruising is usually not observed if you use the non-insulated needles, because on their way down, giving the energy and the heat to the surrounding tissue, they also coagulate the vessels, so there is less bruising. Now, the first generation were these insulated needles. Only the tip of the needle emits the RF. They have a rather low heating volume. That's because of that, you need multiple passes or more passes. So the treatment takes somewhat longer. And we have these microbleeding points. Now, the second generation is the non-insulated, the impedance differences between the epidermis and dermis. And this is the reason why it protects the epidermis from damage. That's due to the impedance. And it has a better effect, as I mentioned, on the dermis than the insulated needles. So the insulated needles have no coagulation on and along the needle, so we have the bleeding points. How the non-insulated microneedles have the coagulation along all the needle, which means no bleeding points. In terms of time, the insulated needles need more than one pass, and the non-insulated usually need just one pass. And these are the three parameters. We were talking now about the needle's depth, which makes the difference. But however, there are also power and pulse width. And this makes it sometimes different in the effect. So if you have the same power, but have a small penetration only, like in 1.5 or 0.8, then still a shallow depth can sometimes be more aggressive than a longer one due to the energy density. Now let's go to point 3, the basics and what makes the difference. These are the other parameters as mentioned, like pulse duration, fluence, and continuous versus pulse delivery. The most frequent mode we use for tightening and for acne scars is the continuous wave. So we have a pulse that is going for a certain period of time. And here what makes a difference is the pulse duration. We have 4 pulse duration in this device, which is, you can see, differ in duration in the length. The CV continuous wave 1 is shorter than continuous wave 4. We'll use the 1 for increasing of the circulation. We use the 2 for face tightening in skin type 2 to 3, the 3 in face and body tightening in skin type 4 to 6, and the 4 is probably the one that I use most frequently, kind of in all skin types for tightening mainly, but also for stretch marks, scars, acne scars, even for double chin. What we see is a coagulation around the needles where we penetrate, as you see in these graphics, where it causes some coagulation. And by doing this, it causes some immediate tightening, and then it causes some collagen renaturation. Now, by selecting the pulse durations, more or less longer or shorter, which is the exposure, and by changing the intensity, like here, from 5 to 15, you can make a difference. And then also you can make a difference by penetration depth. So I quite frequently do a double layer treatment in order not to overtreat one single layer, but to have a more intensive result. That's in terms of lengths. So I do, for instance, 0.8 millimeter penetration and 1.5 or 2 millimeter to get the deeper effect. And in terms of intensity, it depends on the thickness of the dermis and the epidermis, and also the indications. For scars, for deeper scars, you take longer exposure and higher intensity, as we see on the right side. So we are quite flexible. Now, this specific device that I'm talking about today has something very special. It has a new way of delivering the radio frequency through microneedles. And this is a pulsed wave instead of a continuous wave. And that matters for the treatment of vasculature and pigmentation. So we have many small pulses instead of a longer continuous wave. And these pulses, as you can see on this graphic here, and you can see it also on the desktop or the display of the device. Beside the CV mode, the continuous wave mode, you can choose the PW, which is a pulse wave. And you have 4 pulses in various durations, smaller, shorter, and up to PW4, longer pulsed waves. However, always pulse. That means you have less heat occurring because you split the pulse. Still, you have accumulation of heat, which mainly hits the vessels. And the number 1 is an application for Asian melasma, because if you're there too aggressive in Asian skin, you might even deteriorate the melasma than improve it. It's also used for pigmented lesions. 2, the same for melasma skin type 4 to 6. The 3 and 4, due to the longer pulse duration, is meant for more for vascular lesion, for inflammatory processes like acne, angioplasties, nevus flammeus, port wine stain, that you can see. Here we have the histology and electronic microscopic electronic pictures. This difference was proven and documented in 10 clinical pictures and in 10 clinical publications. Now let's have a look on the indications and what we can achieve. First, we have the medical ones, but we also have the aesthetic ones. Let's have the look on the medical ones first, which includes acne scars, vessels, rosacea, and hyperhidrosis. Before we treat, I usually do some pre-treatment with anesthesia cream like Amla or 40% lidocaine prescription cream, or which is very effective, I do one pass of microneedling using the 0.5 millimeter penetration depth, however, without radiofrequency, and using such a very shallow superficial penetration, the patient usually does not feel very much pain with such a little of needle penetration. But what you do is you perforate the skin and you prepare the skin for drug delivery, which means then I apply some topical lidocaine cream, which penetrates faster and deeper and more effectively and anesthetizes more intensively. What you also can do, I've learned that from some of my colleagues, they start with a superficial 10% TCA peel. And while doing that, they apply 1 syringe of lidocaine on that usually is for injection. They apply it superficially, topically, but after the TCA peel, which increases the penetration, like the perforation I did with the microneedles. And what you also can do is use the lidocaine in small mesocannulas and multiple superficial injections. So the pain of the injection is very little, but the effect of anesthetizing the whole tissue is sufficient. Let's show you a few pictures, like after 2 treatments, acne scars. This is something I would treat usually with a 0.8 and 1.5, but 1.5 millimeter penetration would probably be good enough, and I would probably treat this with a continuous wave. This is an older lady still suffering from inflammatory acne, but also suffering from the result of the acne. There are always new scars coming up, and in addition, she has a need for some tightening. And that's why in such cases, we could use, for instance, 2 penetration depth of 3 millimeters and 0.8 millimeters, maybe even a third pass superficially of 0.5. And the older people are, the more passes you should maybe choose. Then we do maybe 2 to 3 passes. We have documented this in an early poster. That's an inflammatory acne plus acne scars, or they look like large pores. That's something that you can use the very shallow 300 micron penetration or 1.2 millimeter in periorbital, and on cheek 2 millimeter. And since this is inflammatory, here you can use the pulsed waves of a higher level 4 with 1 pass, because you reduce the vascularization and you reduce the inflammatory acne. That's one of the scratch scars, the artificial scars that we see in young adults quite often. That went perfectly, it almost disappeared entirely after 6 treatments. That's an accidental scars in a young adult, a man, after 6 treatments. Still, we have to wait 3 to 9 months to get a final result, because what we initiate is not an immediate result. So the best result will be 6 to 12 months after the series of treatments that we do probably once a month. Same accidental scar on the cheeks, 3 months post 6 treatments. Now, indications which are related to vessels like rosacea and telangiectatic. For that, we have that pulsed wave mode that I mentioned. And for vascular, we select the number 3 and number 4 with the longer pulses to get a more intensive effect on the vessels. There is from the company a table that helps you to select the right parameters. For instance, let's take mild redness rosacea. We have 0.8 to 1.2 millimeter penetration depth. We can select the number 2 protocol. If it's more severe, we select number 3 protocol, and a power level of 4 to 5 to 6. It might go higher. So it depends on the intensity of the number and the size of the vessels. Same is true for the passes. We do one pass, see how it goes, and then we can maybe repeat it up to 6 times if necessary, but we always wait 1 month in between. Now, some clinical examples published in some publications. That's a pustular rosacea from A baseline to D at 4 weeks after 6 sessions. In between is the course. Number B is at 2 weeks after 2 sessions. Here, the pulse type was used bipolar alternating current of radiofrequency. They did 6 sessions at 2-week intervals with a power level of 3 and a penetration depth of 1.5 with 2 to 3 passes. Always make sure that you are gently pressing the disposable tip on the skin. Otherwise, it does not penetrate thoroughly and perfectly as it should be. Similar situation, but more larger vessels on the tip of the nose associated to pustular rosacea, with pulse type, radiofrequency, again bipolar. Here, 12 sessions were needed at 2-week intervals, power level 3, same as before, 1.5 millimeter, also same, and 2 to 3 passes, gently pressing on the tissue. A new indication, which is published and described in still very few publications, is hyperhidrosis, because in hyperhidrosis we want to target the sweat glands, which are located a little bit deeper in the tissue. And by delivering heat via microneedles, we can shrink the glands as a result of direct damage to the sweat glands. We can reduce the number and size. However, we need the longest needles that we can get because the sweat glands are located relatively deep. So we need 3.5 millimeters. And by using 1, 2, or 3 passes in an area with a longer pulse of 400 milliseconds, and a medium to higher power, depending on the patient can stand it, we can achieve a 50% reduction even after 1 treatment, and approximately 80 to 90% reduction after 2 treatments. The irradiation endpoint should be when small pinpoint bleedings are visible within the targeted area. We need some ice packs or air cooling that can be applied before and during the treatment and 10 minutes after therapy, just in order to reduce the heat damage to the epidermal skin. And we can do treatments 1 month apart. These are some publications who have shared their experience in 20 patients, 2 sessions of FRM at 4-week intervals, measured the hyperhidrosis disease severity scales and photographs, and also the TIBA meter, which measures the sweating intensity. They also took skin biopsies and did local anesthesia topically, and the 3 millimeter needle. The result was 75% of patients saw a score reduction of 1 to 2, 70% of more than 50% improvement. Also in the clinical tests, in 95% improvement, or even histologically, they found a decrease in number and size of apocrine and acrine glands after months. The side effects were minimal discomfort, transient swelling, and post-inflammatory hyperpigmentation. Now let's go to the aesthetic indications, such like stretch marks, wrinkles, rejuvenation, large pores, laxity, and finally melasma and pigmentations. Stretch marks can be done with 1.5, for instance, 3 sessions 2 months apart. Superficial wrinkles with a 0.8 or 0.5, same here. You might need 3 to 4 sessions within 4 months. That's also perfectly around the eyes. First, I would immobilize the muscle activity by botulinum toxin in order to have a relaxed skin, and then we can create some more collagen by doing the FRM treatment. Wrinkles and larger pores in the sensitive areas, large pores on the chin here, that can be done with 0.5 and 0.8 millimeter penetration depth and a medium intensity. Laxity needs deep penetration, 3.5 millimeter, maybe 2 to 3 passes, high intensity of the fluence, and longer pulse duration, and probably 4 combined treatments. The very specific indication and situation about the device that we are talking about today is that we can treat melasma and pigmentations, not just by targeting the pigment, but also by targeting the underlying vasculature. If we look at pigmentation, we have to categorize if it's epidermal, dermal, or if it's mixed. Sometimes melasma is mixed, but can be epidermal or dermal as well. And the others also. There are some that depend more on vascularization and some less, like lentiginous epidermally depend usually a little bit less on vascularization, or blue nevi, but melasma and skin aging depends on vascularization. Again, here the classification of epidermal, dermal, and mixed melasma, we can differentiate with value microscopy and the various pattern that we usually see in the clinical pictures. Below this pigment, we find some dilated vessels, and we know that melasma has an increased vascularity. We know that from histology and also from microscopy. We have the epidermal pigment and below subepidermal microvessels. And we know also that we can, with lasers, treat that successfully. So increased vascularity is one of the major findings. We now know that the interaction between the cutaneous vasculature and the melanocytes play an important role in the development and maintenance of the melasma. The number of blood vessels, size, density are greater in lesional melasma skin than in perilesional. And immunochemistry has shown that factor 8A related antigen revealed enlarged and elongated blood vessels in the epidermis compared to perilesional skin. That's what we can treat with a pulsed radiofrequency, not with a continuous. The continuous might be too strong and might initiate more pigmentation. But if we do the pulse way, we deliver less heat, but we hit the vessels. So the significant increase in vessel size, density, and the area covered by blood vessels is one of the factors of melasma that can be treated with a pulsed, the pulsed way of delivery, the microneedles. From a number of publications, we know that there are elevated levels of cytokines that can affect the vascularization. There are angiogenetic factors that induce the vascular proliferation. UVB initiates this, and endothelin-1 is released from endothelial cell, and that stimulates the pigmentation. So through these mechanisms, vasculature and also UV influence can increase a stimulation that results in more pigmentation. From lasers, we know that they are effective if you have a wavelength about 577, for instance, on the pigmentation and on the hemoglobin. So we can treat both, and that's the same that we do now with the radiofrequency in the pulsed way. Lasers always treat melanin and vessels because they are competing chromophores. Here's the melanin, here are the vessels. Studies on melasma have shown the positive results with lasers targeting the vasculature. There are studies on IPL, on 1550 nanometer non-ablative lasers, Q-switched anti-YAG, on pulse dye laser and copper bromide laser by treating first pigmentation epidermal dermally, but also treating the subdermal vasculature. With a pulsed microneedle RF, we treat the same target. We do not treat the pigment, but we close the superficial vessels in the dermis. For that, for epidermal melasma, so we have to distinguish between these various types. For epidermal, we rather use the shallow parameters like very high or small penetration depth, less fluence, while for dermal melasma, we use a little bit higher fluence, the PW2, and a depth of 0.8 to 1.5. For PIH, we still use about 1.5 millimeter depth, PW2, and a power level of 4 to 6. For hypopigmentation, we can use about the same parameters. Some case reports, this is a melasma between A and B after treatment. That was a treatment at level 3, 1.5 millimeter penetration on the face, and a level 2 treatment for the forehead, 1 millimeter. And then in total, it was 5 to 10 treatment sessions in 2 to 3 week intervals. Another case, 5 female patients treated with refractory facial melasma, 4 to 7 treatments, 1 week interval, power level 3 to 5, 1.2 to 1.7 millimeter penetration in one single pass, achieving 50% clinical improvement and more. And the combination of microneedle radiofrequency and Q-switched NDAC laser did better result, achieved a better result than both as monotherapy, which can be expected. Another publication showing 5 to 10 treatment sessions and significant reduction of the pigmentation, and also high patient satisfaction after 7 to 8 sessions. And we saw the decrease of senescent cells as well, with increased expression of procollagen 1, which was associated with reduced epidermal pigmentation. The redness is decreased. I speed it up a little bit, but we come to the end. Again, here, superficial ones, we choose the superficial penetration, power level 5, 1 pass, and a more shallow indication of PW1, pulsed wave, still a pulsed wave and not continuous wave. Again, here, redness and melasma, pulsed wave on 0.5 to 1.5 millimeter, power level 5. Same in this. So in summary, pigmentation, especially melasma, is and also aging skin is vascularization dependent. It can be targeted together with a pigmentation by new non-laser technology like this pulse type and not continuous type bipolar, which also means superficial, alternating current radiofrequency using the microneedle electrodes. And want to remind you again, these microneedles help not to target too much of the melanocytes because it penetrates deep and then delivers the heat. So we have less damage to the superficial skin and epidermis, but also not as much to the epidermal-dermal junctions where we could initiate repigmentation. Some reading, if you like to read about facial rejuvenation, there is a book by John Libby. And I would like to invite you to our 5-Continent Congress in Barcelona, which will be live again this year, September 1st to 4th, with all the range of aesthetic, laser, and some clinical medicine presentations of the top world faculty of more than 100 speakers. Hope to see you there. And so far, thank you very much for your attention.
Thank you, Dr. Fritz, for very academic and excellent presentation. So why don't we start Q&A session right away? So we have some questions from the audience. The first question is, I have seen punctuated hypopigmentation in derma pen use. How do you do that?
Did I get it right? You have hypopigmentation after use of a derma pen.
Derma pen use. Derma pen
Pen is
treatment.
just a microneedle without any radiofrequency, right?
Yes.
Yes. Well, it depends how long ago this is. Probably the damage was a little bit too high. What I would do is probably a very shallow, with a pulse wave, a very shallow penetration of 300 microns or 0.5 millimeters, and a very, very low radio frequency in terms of kind of a stimulation, not of a reduction of the vascularization, so that we initiate some repigmentation of these tissues. Usually repigmentation can occur if we stimulate the tissue. So if we want to do it with this device.
What do you mean by one syringe of lidocaine? Concentration or mode of administration?
This is the syringe that we could use for subcutaneous injection. So the syringe I mentioned this because some do a 10% TCA peel in order to break the skin barrier and then apply the amount of one syringe to the area like on the cheeks. And that amount of lidocaine is sufficient for the cheeks to be anesthetized if you apply topically.
Okay. May I ask how long the result hyperhidrosis lasts?
Well, once you have destroyed the glands, the sweat glands, then they don't regenerate. Okay. So it's a permanent. The only thing that it might have to pay attention is if there are nerves on vessels around, because we go deeper with 3.5 millimeter, and if we use a higher fluence and longer pulse duration, we need a little bit more of a significant heat which penetrates really deep. So I would also add some pressure to the microneedles to make sure they penetrate as deep as they can.
Okay, and do you have experience on port wine treatment?
I have little experience for that. I must say, if you have this device, you can try on it. However, more the superficial areas. It is probably not the main device to treat this kind of indication. However, what we see from port wine stains is, even if we have done 12 sessions of pulse dye laser and have treated some nodules with the deeper penetrating Nd:EG lasers, we still have on one side reoccurring vessels that need to be treated again and again. And the second is that there are a number of areas which are not perfectly disappearing or very hard to treat. Also with the lasers, we know that we sometimes have to change the approach. We either have to go for a deeper delivery or for a more superficial delivery, or choose a different wavelengths. And I see this as an option from this device to use, instead of lasers, to use just the bulk heating that we apply, but with the microneedles. However, I think we need to, if it's a very subtle vascularization and more epidermally, we can use the 1.5 to 2 millimeters, and in a lower dose and in a pulse dose, in order to just get the coagulation of the vessels. But if the vessels are still very strong and very filled and the size is larger, you have to choose the deeper penetration, high fluence, and longer pulse duration, then I would use the continuous wave, and not the pulse wave.
Okay. How do you differentiate the depths of melasma? What is the rationale of using hypopigmentation?
You can see by dermoscopy if it is more located superficially or more deeper. You can also use some video microscopy picturing, which allows you to differentiate if it's deeper or less deeper. Finally, you could do a small 532 nanometer laser treatment superficially and see how it reacts, because the deep penetration reacts less good on that. Usually we should not use 532 in melasma because it irritates too much. Usually it's a more kind of a large spot, low fluence 1064 that we use, especially in darker pigmented skin. But the main tool is dermoscopy.
Okay, and do you use deeper than 1.5 millimeter for scar treatment?
Depends on the depth of the scar. If I have like the stretch marks, or if I have deeper stretch marks, or if I have atrophic scars, I think I would like to stimulate the dermal tissue to build some new collagen and to do a little bit more of a tightening effect, because it should come from below in order to flatten the stretch marks and the scars. You can't flatten them by treating them very superficially. There's only scar. There's nothing that you can stimulate. You only can, if you treat superficially, then you can perforate the fibrous tissue, which increases the vascularization and improves the scars. But that's a different approach than creating new collagen from below.
If the patient has multiple skin problems like scars with redness, how would you treat? Which modes will you utilize?
Well, redness will disappear due to the vascularization effect and coagulation effect, just also because of the non-coated microneedles. Since they deliver the radiofrequency and the heat around the needles, they will also close these vessels partly, not all of them. You don't treat all of the vessels because you treat it in a kind of fractional way. So I expect if you treat scars and this is red in addition, then both will be reduced.
Okay, few more questions. If more than 2 passes, do you do the deeper depths first or shallower depths first?
I do the deeper pass first.
And can I ask about stretch mark settings?
Stretch mark settings, I would use continuous wave, let's say 2 millimeter and 0.8 millimeter for a standard. But you know, stretch marks can be deeper, they can be more wider, they can be smaller, so it depends individually. But let's do an average one. So I would do usually 2 passes because I need a little bit more of energy to get some tightening and collagen, new collagen production induced. But I will also have like to have a superficial effect. So I do 2-layer treatment, and the deeper layer I do with higher parameters than the superficial layers. It also depends on the skin type. I mean, if this is a skin type 4, we have to be a little bit more cautious because of the repigmentation or hyperpigmentation that could result from the superficial high energy. So I would do that lower in a darker skin type.
Okay. It's time to wrap up. So if you didn't receive any answers or have additional questions, please contact us by email. I'd like to thank Dr. Fritz, who gave the great lecture, and the audience who participated in today's webinar. Have a good rest of the day and see you next time.
See you. All the best to you. Thank you.